The executive system of government is too expensive if we must be honest to ourselves.
I'm in support of having a state police and even having local government police.
Those who want to invest had better come in now, because Nigeria is going to change and change for good.
We have given in to sentiments that are tribal or religious or political.
Whoever is honest in politics will begin to run into problems. In fact, you will not get elected.
I think you must be guided by certain principles.
Me, I like my country. I like the land and people. Everything is there for Nigeria. Make we join hands to make Nigeria better.
True Nigerians, heroes of our time. Let's go there. Hello Nigeria and hello Nigerians. It's that time again of True Nigerians, heroes of our time, a program where we bring to you Nigerians that are role models, Nigerians that are worth emulating, Nigerians that have done us well in the Federal Republic of Nigeria. My guest today on the program studied medicine at the Ahmadu Bello University and graduated in 1995 with Bachelor of Medicine, Bachelor of Surgery honors, Masters in Clinical Research, University of Maryland, USA, PhD in Epidemiology, University of Maryland, USA. Also worked as Country Director, University of Maryland. His CV is so long, it's like when a doctor writes prescriptions for you on the sheet of paper, you can't read those grammars. There are so much. In fact, I have so many questions to ask even in a CV for some that I saw that I don't even know what it means. My guest on the program is the Director General, National Agency for the Control of AIDS, NACA, Dr. Gambo Gumel Aliyu. Thank you very much for having me on the program, sir.
Thank you.
Okay, as you can see, we're struggling with your CV. Your CV is this big. I have tried to summarize it, but I think I will let you continue. But while you continue, I also want to know, because while I was going through your CV, I saw some. These are my questions. What is PEPFAR? There was something on PEPFAR.
Right.
I didn't know what that is. Maybe you may need to continue on your CV or from where I stopped, sir.
Yeah, you have summarized the CV, so okay. I think you pretty did a good job. I studied here in Nigeria, first degree medicine, and I did a master's and PhD program at the University of Maryland, United States, as you said. And I also worked there, and I did some fellowship there, and I went to University of Manitoba in Canada, and I did another program, a fellowship, before coming back here, Nigeria, to work for the same University of Maryland as country director at one time.
In Nigeria.
Yeah, in Nigeria. Yeah, the PEPFAR you're referring to is a program.
Okay.
It's actually the US program that is supporting HIV globally. Okay. Not only in Nigeria. Okay. It's the President's Emergency Program for AIDS relief. So that's what PEPFAR stands for, US President.
Okay, there was another one that also have in-depth in something.
So these were our earlier trainings, my trainings in the States way back in like 2003. That was the first time I went to the United States for training, and that training was basically on training Nigerians on how to create centers of excellence for treating HIV, for preventing mother-to-child transmission, before the emergence of this current PEPFAR program.
Okay.
Yeah.
So and what is NAIIS?
Okay, that one is a survey we did some 2 years back. It was the government of Nigeria and the US government together, the Global Fund, that called for the survey. What we did as University of Maryland then was to tell them we are making ourselves available if they need a vendor to do it. And they obliged us, even though it was competitive. Actually, we applied, we competed with other institutions globally. And we were lucky we were given. So when we were given, we implemented it on behalf of the government of Nigeria and the US government. And I happened to be the person on the driver's seat when that one was done. Yeah.
Well, you also have so many research on with your name on it. Can you mention some of those research, some of the key ones? I know there are so many, but at least
they generally have something to do with either HIV, TB, or HIV and TB together.
Okay.
Yeah, I think my career began with research here in Nigeria at Asokoro Hospital. And that was way back in like 2003, where we were helping the CDC to find out the way the body defense mechanism behave when somebody gets HIV infection with HIV virus that is circulating in this region. You know, the kind of HIV we have differs with the HIV that exists in Europe and America in terms of there is a structure, there is some kind of difference. So that's the category we are calling here a category that is unique to Nigeria and is found only in Nigeria and some neighboring countries here. And there is the type that you find in the United States and in Europe, and there is another type you find in South Africa. But they are all HIV viruses.
Are their
only that
treatments
they
different?
are different variants.
Okay.
So they're looking at blood sample of individuals that have early infection with this type of HIV that we have, so that they can look at this immune system and see how it changes over a period of time when somebody gets the infection, early infection or new infection. So that was what we were looking for. And the purpose actually is to optimize an assay. There was an assay then under development. For it to work on every clade of HIV virus that is existing globally, they need a bit of information how that clade behaves, so that they put together and now come up with one test that will respond to every type of HIV. So that was how my career, I think, started in research. So we were able to assemble these panels of SERA, they call them, from people with early HIV infection and make available to them. Over a period of time now, those tests now are in circulation, they're available. They are called recency tests. When they test and they find out you have HIV, they will tell you whether this HIV is an infection that you get recently or is an infection that has stayed long in you.
You see, I think I was carried away, so I couldn't even wait. I'm jumping my questions, but we have a traditional question. I'm just excited because I know there's so much Nigerians we learned from this particular episode, especially in regards to HIV AIDS.
Right.
But our traditional question, what is your definition of a true Nigerian?
A true Nigerian.
Yes.
I can define that one as a responsible citizen of Nigeria who puts the interest of Nigeria above his personal interest. That would be my simple definition.
Perfect. That's all in one, sir. Okay. Before the COVID-19 pandemic, there was a lot of attention. You know, our focus, the most deadliest thing we know of then was HIV/AIDS. It was the center of attraction, you know, the cure for HIV/AIDS and treatment and all sort of things. But the COVID-19 has massively taken the attention of people out of
HIV.
The dangers of HIV/AIDS.
Right.
And plus the lockdown, the many sexual activities during the lockdown. What have you been doing? What are you doing to address this new pandemic situation in regards to HIV/AIDS?
Thank you.
Yeah.
With regards to lockdown, we don't have evidence of more sexual activities. You know, we work on evidence, we work on facts. So we don't have evidence of whether there was an increase in sexual activities or not. But what we always caution people is risk-taking.
Okay.
Even if there is no increase in those activities, if the activities that people usually do, they don't protect themselves, or they don't take measures to make sure they don't have the virus if they don't have, or they don't give others the virus if they already have, then that can result in new HIV infection. But the attention, yes, you're right, attention has been diverted to COVID because COVID is the new thing, and because COVID kills quickly. You know, HIV doesn't kill quickly. It can remain with you for as long as, you know, your body defense system is able to contain it without showing on somebody's face. But COVID is different. But all the same, we had some kind of distraction, but now we are back on track. During the COVID lockdown, we were not able to identify as many people as we regularly identify every month. You know, this is a phase that in HIV control that is a bit difficult in the sense that you have identified all people that are easy to find. The remaining people that are not identified are people that are not easy to find, people that are difficult. This group of people, you have to devise a strategy that matches the category. If you use the same strategy, as somebody was asking me a question the other day, that why are you not doing the regular campaign thing you do? You say A, B, C, and all these things. Say, well, we have done that, and that has worked on people that it actually worked on. But there are a category of people now that, one, we don't see them. They have HIV. They are in our society, in our midst. They are up to around 500,000 or so. They have not been identified. And for us to control HIV, to make sure we control HIV and we prevent, we end AIDS, we have to identify these individuals. And getting to find them is not easy. That's why you now see more activities in the community, going to people's house, talking to them about HIV, in addition to what we do at the facility, and trying to find out people who have new HIV infection. Because those who have new HIV infection are the people that have this virus in uncontrolled, unchecked volume. It's there, is multiplying in them without check, and they give it to people at minimal contact. So if you get them, you identify them, and you stop the transmission, you put them on drug, the drug will check the virus. Even though the immune system is studying the virus, is yet to start fighting the virus. And that is why the virus, you know, in them is unchecked and multiply uncontrollably. So these are the group of people that we are going after. So if we're going after this group of people, then definitely we have to do something extra, something different, kind of out of the box thinking, and that's what we do now. Yeah.
Okay, but the people that another question is, it's been said severally that people with underlying illnesses will not survive the coronavirus.
That's true.
What chances does someone who has HIV AIDS has? What chances of survival does he has?
So this is what we are looking at now. Those data are what we are looking at now to see what impact COVID has on HIV. At the beginning, we haven't seen it globally, but lately, you know, we've seen some reports from places like South Africa that are indicating or showing evidence that people who have HIV actually are at increased risk to get COVID, and when they get COVID, they are at increased risk to suffer devastating consequences, including death, compared to people that don't have HIV. Such trends we haven't seen much here in Nigeria. We haven't seen evidence to that, but we're looking into the information we have because the problem is some of the patients, or most of the patients that are identified with COVID, incidentally, you may find out that they are not non-HIV patients. So maybe they have diabetes, maybe they have hypertension, maybe they have cardiovascular diseases. But before then, we don't have them on our record that they are non-HIV patients. Even if they have HIV in them at the time they died, we don't know. That's it. But for the people that we know, that they are on our record, that they are HIV positive, we know they are taking our medication, we haven't seen that increased occurrence of COVID among them.
Okay, so you've not had any chance of knowing about any patient that was HIV positive that has, I mean, you've not had any case like that so far?
We're looking at the data. Maybe it's there, we haven't come to it. But if we do come to those cases, we will review them and we'll follow up and see how it ends. But for now, we haven't gotten any report that will take our attention towards that line to say, oh, we are seeing more people, more HIV people that living with HIV getting COVID or dying from COVID when they get it.
Okay, generally, let's say nationally, in regards to HIV/AIDS, how would you say we've been making progress, and where are we not making progress? What is our status nationally?
Our status has been impressive. We've made a lot of progress in the sense that if you think back 10 years, we're looking at this epidemic as epidemic that is larger than what we are seeing now. Then we're talking about prevalence of 4.4%. Later on, it shrinks to about 3.something%, 2.8%. Today, we are talking of prevalence of 1.3%. Coming down from 4.something, or 4.4 to 1.3, you've taken down 3.1 off. So that's huge. And if you look at the number, we're talking several years back, we're talking about 3.5 million people living with HIV AIDS in Nigeria. Today, we are talking of half of that number, 1.8 million people living with HIV AIDS. So I think we have made tremendous progress, both in the science, how we estimate, how we make these calculations, and also in management side, how we identify individuals and how we put them on treatment and how we maintain them on treatment, because that is what matters. Now, maintaining them on treatment will guarantee suppressing the virus. And once this virus is suppressed to an extent that we don't see it in your blood, it's very unlikely that this person will give HIV to another person.
Okay, when you say maintaining them on treatment, does it mean, is the treatment free, or is, I don't know?
The treatment is free. The treatment is free. The only thing individuals are required to do is to seek for it. If you know your status, you are HIV positive, ask. And if you find it difficult, call our line. We have a line dedicated, 6222. This is dedicated to serving people who have HIV and to serving individuals, general public, about information about HIV, how to protect yourself from getting HIV, and where to get HIV services given the locations you are, the location where you are situated right now.
Okay, this also brings us to the issue of funding. In terms of allocations, accurate allocation of funds and implementation, implementation and allocations of funds that you get from the federal government or international donors. What measures do you have in place to make sure that these funds are channeled towards the right places, what they are meant for?
The funds are channeled to places they are meant for. There is no doubt about that. For the international development partners like PEFA and Global Fund, the money doesn't come to us. It's handled by them, and they implement this program at the grassroots, and we are seeing results. We have people that go out and monitor, and we see the kind of services that are being provided at our facilities. We have about 3,000 facilities nationwide that provide HIV services, especially treatment and care and support services. So we know the kind of services that are obtainable at those facilities, and we are happy with it. If you talk at national level, NACA has never had resources like the way we have last year and this year. So the government has done extremely well in providing those resources and in providing the necessary support to make sure whatever support we're looking for in terms of getting drugs on time, in terms of getting kits on time, in terms of moving commodities, where they need it to be, we have all the support. So as I'm talking, last year the government of Nigeria was supporting 50,000 people on treatment. This year, government has doubled that amount. We're supporting 100,000 persons that live with HIV in terms of their treatment, coming from resources that are given domestically, not from the development partners. So that's huge progress from 50,000 to 100,000, just in a span of a year. So, but for the development partners, you can see they have up to about 1 million plus, 1,100,000 or so that they are treating, and they have been treating this. This number has been increasing for the last 15 years.
The number of the people
on treatment has been on the increase. Yeah, because you identify people daily, and then as you identify, you put them on treatment. Last 3 or 4 years, they were not up to 1 million. Now they are 1 million and 1 million plus. And we expect this number to continue to increase as we identify more people out there in the community that have HIV and put them on treatment. Because that is key. If at all we want to end HIV AIDS, we want to end AIDS, we want to make sure that this is under control and people are not getting it and people are not dying from it, we have that one responsibility. One, to identify people that have the disease, and 2, to place them on life-saving medication.
Life savings. Well, let me not say anything, but life savings, that sounds very expensive.
Life-saving medication. Okay. the drugs or the medicines that are used to treat HIV, they are life-saving in the sense that they prevent One, the virus from destroying the body defense mechanism, which is actually what kills. It is not the virus that kills. It is the virus destroying that body defense or the body protection system that exposes the individual, to all
sort of
illnesses and diseases and eventual death.
Okay, take for instance in a factory, like a beverage company or a soft drink company, where once in a while there could be an accident, and assuming maybe a cut from someone who is HIV positive, that could kill millions of lives. That would destroy a lot of people unknowingly. Now, one way think, what kind of synergy do you have with NAFDAC, the food agency, in terms of protecting Nigerians from the dangers of that kind of accident, to make sure it never happens? And okay,
go ahead.
I wanted to ask if we've ever had any case like that before.
We have not had any case like that before, and I doubt much we will have, for two reasons.
Okay.
One, the HIV virus as it is a very weak and fragile virus. Outside the human body, it doesn't stay long, and small amount of heat or pressure can kill it. So it's a virus that does well inside the body and does not do very well outside the body. So that's one thing. So if it is by accident, exposed to heat or exposed to anything, as you're saying, beverage, and I know this kind of places, usually they run things at different temperatures. So if it is exposed to a temperature, that is slightly higher than what it is, it can get killed easily. Second, hardly do you see people working in these factories without protection. And that protection includes the gloves they use. Most of the time you see people will be given these gloves, one, for protection, and two, to improve hygiene.